Thank you, and good afternoon, everybody. Welcome to our webinar, and good morning to those of you on the farther west time zones. This is Mike Fraser here in Washington, and we're pleased to offer this webinar. I think this is one of the best titled webinars we've ever put together. I'm really excited about it, the ABCs of ACOs for MCH. It's got a great ring to it, but also we're going to have a lot of great information presented on a issue that I know is in everybody's minds. What is an ACO? What does it mean for our work at the state maternal child health level? And we're going to hear some great case studies and insights from several different states, Oregon and Virginia, and we're hoping to get comments and questions from the group as well. We've joined by some wonderful resources for AMCHP, and to get us started, I'm going to turn it over to our senior advisor and our policy team, Karen Van Landehan. Karen?
Thanks, Mike, and good afternoon, everyone, and welcome again to the AMCHP webinar, the ABCs of ACOs for MCH. My name is Karen Van Landehem, and I'm a senior advisor with AMCHP working on health reform. And we're just really delighted that you're taking time out of your day to be with us on this webinar and to talk about an issue that is of real interest to state Title V maternal and child health programs, public health professionals, and others working on ACA implementation, and that's accountable care organizations. AMCHP and its members have had a long-standing interest in leadership roles in healthcare reform, dating back to the Medicaid reforms of the 1980s and before even that, to the passage of the Children's Health Insurance Program in 1997 and the health reform discussions that happened during that time, to the passage of the Affordable Care Act in 2010. When the ACA passed, AMCHP established the National Center for Health Reform Implementation to provide resources, technical assistance, and support to our members and colleagues, and to make sure that there was a forum for MCH professionals and others who were interested in assuring that the unique needs of women, children, including children with special health care needs and their families, were considered in the passage of the ACA and also in its implementation. And since that time, the National Center at AMCHP has produced numerous reports and fact sheets and national webinars like this one and other technical assistance opportunities. You can find those and many other resources on health reform from the MCH perspective on our website at www.amchp.org under the tab Health Reform. I just want to acknowledge a few folks. I first want to acknowledge and thank Dr. Chris Kuss, who is the co-chair of AMCHP's Legislative and Healthcare Finance Committee, and he's going to be moderating this webinar. It is really the work of that committee that has guided development of this webinar. I want to thank Carolyn McCoy for organizing this session, and finally, just a big thank you to our presenters. So I'll turn this over to Carolyn for some logistics and housekeeping, and then she's going to turn it over to Chris to moderate our session. Carolyn?
Hi, Karen. Thank you so much, and also thank you to Mike for joining us today. My name is Carolyn McCoy. I'm the Senior Policy Manager here on the policy team at AMCHP. And again, I'm seconding Mike and Karen's thanks and gratitude for taking time out of your busy schedules to join us. And we are very excited to be able to provide this webinar to you all. So moving on to some of the logistics, I wanted to make sure that we're all able to hear and see that the audio is coming through your computer. If not, please dial the web support phone number, and they will give you the phone number to call in as a backup. Or actually chat into the chat box on your lower left-hand corner, and we will provide you a backup phone number as well. We really want to hear from you, questions, comments, thoughts. We encourage you to submit them all throughout the webinar to the chat box down in the lower left-hand corner. Being that this is a broadcast audio webinar, this is the only way that we will be able to hear your questions, and we will take those at the end of all the presentations, as well as having a few minutes in between each presenter for burning, clarifying questions. But just to remind you, if you have a question, just go ahead and submit it. The webinar will be recorded as a reminder, and it will be available on the AMCHP National Center for Health Reform Implementation website within the AMCHP website. So please visit there in a week, and you will be able to also find the presenter slides and PDF version. There will also be a very short evaluation sent to the attendees of this webinar afterward, and we really appreciate taking a few minutes to submit your comments and your thoughts so that we can improve our work as we go along. So finally, I'd like to turn this webinar over to Dr. Chris Kuss, and Karen provided a little bit of background on him, and he is the he's on my other page. He is the Associate Medical Director, the Division of Family Health for the New York State Department of Health. And as Karen mentioned, he's also the chair of the AMCHP Legislative and Healthcare Finance Committee and a past president of the AMCHP itself. So Chris, without further ado, I'd like to turn it over to you.
Thanks very much, Carolyn. And I think this session really does talk about new information for folks, because I think accountable care organizations have been doing work in the adult care field, less in the pediatrics, and we're going to hear from some speakers who've been involved in that, and particularly look at the idea of maternal and child health programs and their role with it. I think I'm a good moderator in this case because New York, we haven't done much with this yet, and I'm really interested to hear from the speakers. As part of this hour-and-a-half webinar, we hope that it will increase your knowledge of the affordable care organizations, and that affordable care organization and of affordable accountable care organizations that include MCH population. That's kind of where we got the presenters for this. We want to increase your understanding of how public health can play a role in ACOs, accountable care organizations, and we'll learn to identify strategies and resources to collaborate with ACOs in your states. As Carolyn mentioned, we're going to be taking questions looking at the chat box, so please put those in. And particularly, we're going to go through the presentations and then take the questions. But if there's a clarification question, note that in the chat box, and we can probably bring that to the attention of the presenters before we move on. But generally, we're going to have enough time for questions at the end of this. It's interesting because as I'm preparing for this, the June edition of the JAMA Pediatrics came out, and there's a viewpoint in there from Dr. Charlie Homer from NICHQ, and also Dr. Patel, and the title of this viewpoint is Accountable Care Organizations in Pediatrics, Irrelevant or a Game Changer for Children. And we'll send this on to folks because I actually went to JAMA and it's not up on the website yet. It was just in the print. But I think we're going to hear about the concept of accountable care organizations. We do know that the Affordable Care Act talked about these, and in fact, the Affordable Care Act calls for the establishment of a pediatric demonstration project, although the specified starting time for the project, June 2012, has passed without any guidance from the U.S. Department of Health and Human Services. And I'm taking this directly from that viewpoint. And so I thank Charlie and Dr. Patel about this. The concept is really the idea of, and you'll hear it from the speakers, about moving from a system of care where we pay for procedures to a system where we're paying for performance. And you'll hear one of them talk about the accountable care, so that the accountable care organizations themselves will include healthcare providers, primary care specialists, hospitals, and others who join together to provide care for a defined group of patients. And the promise of this is the idea of having improved care and cost control, and the role for ACOs is that in return for reducing total cost and meeting quality metrics which have improved for kids, the ACOs can share in the cost savings. So that's a basic concept, and we'll go through this and how it's played out. We've got presenters from Virginia and then from Oregon. I'm going to start out by introducing our first presenter, who's Dr. Colleen Kraft, who's a professor of pediatrics at Virginia Tech in Carrion and happens to be the chief officer of Majestic Care. And we were just talking about providing majestic care. Now, that's a good goal. So without further ado, Dr. Kraft, you're on.
Well, thank you, Chris. And we're going to be talking about the ABCs of ACOs and making them work for maternal child health. And I'm going to start right in with our goal, which is the family-centered medical home. It's a good place for us to be starting because this is really what we recognize as the best source of care for children. And within our family-centered medical home, we have different populations. It's no longer well care or acute care. We still are doing acute care, but we really have got to be looking at our vulnerable children and families and looking at methods of improving their life course health trajectory. We're looking about prevention and building health. In the meantime, we're also looking at developmental services. What is it that we're doing to promote development for our children? And then there's that group of medically complex children that are really the high utilizers within a healthcare system, but they're the ones with the greatest needs as well too. And linked in with our family-centered medical home are those connections to early intervention, to home visiting networks, to early childhood mental health services, early Head Start, developmental services, lactation, all the different things that we look at as that pediatric medical home, where there are processes in place to care for our population, but the relationship that's there between ourselves and the children and the families. So an accountable care organization, in its most basic definition, is an organization that can include hospitals, includes primary care providers, includes specialists, and they contract with Medicare or Medicaid or a private insurer for a lump sum of dollars. And what they do is work with efficiencies to coordinate that care for shared patients and gain from that a financial bonus of savings. So what the ACO does is they take that block of funding and they coordinate that care with the goal of meeting and improving quality and cost benchmarks. They hire an administrator, establish a formal legal structure to work with payers. They monitor performance and then collect any shared savings. And then a financial bonus, should it be there, is divided amongst its participants according to their agreement. So we know what traditional medical care and financing looks like and how it is really unaccountable care, because what we have done in the past is we have not paid well for primary care, preventive care, screenings, low-cost care. And we've not paid traditionally in medical systems for what we think of as maternal child health services, many of which were done in public health, but there's been a disconnect in many places between home visiting services, home-based care, health lifestyle counseling, and what's happened within primary care practices. What we have paid for has been the high-cost care. So we've paid for hospitalizations and procedures. We have paid for duplication of labs and studies and procedures. We've paid for ambulance care. We've paid for end-of-life care in an intensive care unit. And part of the way that model was propagated was that there was no incentive for communication or collaboration. There was no care coordinators. There was no measurement of outcomes, no comparative effectiveness research, no transparency of finances, and we got the system that we designed. So we got a system where there was poor payment for primary care, so we had a lack of primary care providers. There's high payment, so lots of procedures, and really the outcomes were not where we wanted them to be. So how do we transfer this to accountable care? So accountable care really is looking at that middle block there where we're improving coordination of care and investments. So health information technology that promotes communication and interaction and collaboration. Having office care coordinators to help out with the non-face-to-face care. Using public health services like home visiting, home care, palliative care, and other things to really bring that into your medical home model so you're able to pay for the care that these patients need. Electronic portals for patient communication and collaboration. Having primary care and ancillary health co-location, including behavioral health, including dietitians, data management and that infrastructure to evaluate those processes and outcomes so you can look to see, is this working? And how are we tracking our metrics over time? And what are we defining as quality care? And how do we know that it's happening? How do we know that these changes are improvements? And in theory, what this should be doing is improving the quality of care because we are improving the scientific basis of our healthcare decisions. We have our payment that's tied to patient outcomes, and there's shared system savings. It should be reducing cost of care in that to have this model work, you have to develop robust primary care access. People need to be able to get into low-cost primary care to avoid the ED visits and the hospitalizations that happen if you don't have a primary care access. It's streamlining administrative tasks and the co-management between primary care and subspecialty physicians to avoid hospitalizations. Often a hospitalization is avoided because a primary care physician is able to get information from a subspecialist, and in that collaboration there's a care plan that's made for that patient so that a hospitalization is something that's not necessary. Greater use of home care, greater use of home visiting, and avoiding duplication of care, which again, in a system that communicates, you can find out that somebody who has had head trauma and has already had a CT scan, or that labs have been done on a patient who's being worked up for an endocrine disorder. So the idea of accountable care is in this three-part aim of better health for your patients, better care for your patients, and lower cost. But as we look at this for pediatrics, we really are looking at something different in pediatric accountable care. We're really looking to do what we should be doing, which is optimizing the health and development of all children. And in fact, looking at the prevention of adult disease. And in doing that, reducing the high-cost care, not only immediately with our medically complex kids, but in generations to come. And in fact, that has been the problem with managed care all along, is that people are looking at investments in a 6-month, 1-year, 2-year time frame and not over a generation. And accountable care is understanding that some of that savings is going to come over a generation in time. Because we know what those factors affecting child health are. Half of it is health behaviors. A good proportion is genetics and environments, and really a small percent is medical services. So if you look at how health innovation can be funded through an accountable care organization, the idea is that an ACO works with collaborative partners, and you can divide those dollars in a different way. So rather than dividing a high amount of those dollars for high-cost procedures, you could instead pay a primary care provider a lot more and have more primary care providers. You could instead hire and use community resources in a way that they've not been used before by the medical system. And so what we have done here is looked at in-home management of early childhood, oral health, our prenatal care, asthma, and then development and behavioral health. The model that we have used and have put together here, Carilion Clinic, where I'm employed as a physician, has partnered with Aetna and developed this accountable care organization. And we have 3 products. So we have the one that's the farthest along is our Medicaid product, and that is Majesticare. We have a Medicare Advantage product, and then we're working on a commercial product as well too. And this Medicaid accountable care organization contracts externally with private practice physicians and then internally with our own Carilion Clinic physicians. If you look at where we're located in Virginia, this is a map of the Virginia Medicaid regions here. We are in the poorest area of Virginia. If you look at the pink and you look at the light green and the dark green, that is where we are located in Virginia. We started off, the pink area is the Roanoke-Allegheny region, and then the light green is far southwest, where our health demographics are actually much worse. one of the things that I recall hearing about was this group called the Remote Access Mission, who would go to far southwestern Virginia, Wise County, every year, and they would bring doctors and dentists and optometrists, and 3,000 people would line up to get medical care. And I'm thinking that's more of a global health model. That's not what we should be doing in Appalachia. So we should be doing better with that. What we have found is with our ACO System Savings that we are co-managing between primary care and specialty much better. Much of that has actually been facilitated by Epic, which is our electronic health system, in that we can in-basket each other. And I find that personally as a physician very helpful, because with my really complex kids, I can ask the same question to their cardiologist and pulmonologist and neurologist at the same time and we have a four-way conversation about the patient, which is really what we should be doing. There's less duplication of services. We are able to, with predictive modeling, track our high utilizers, which is really just a proxy for people with high needs. And there's access to primary care, less use of the emergency department and hospitalizations. Just a little bit about the predictive modeling system that Aetna uses to help us out. We are able to find who our top 1% of utilizers are for our emergency department, for our inpatient hospitalizations, and for our emergency, for both of those, for both emergency and inpatient. And we are not just a pediatric ACO. We have adults as well too. And so as you can guess, our high utilizers are adults. But you think about adults and you think about the elderly as being high utilizers, and that's not the case. Even if you look at this, our highest utilizers of the emergency department the average person is 33 years old. 72% of the time she's female. The per member per month cost is $962. 85% has a behavioral health comorbidity, and 58% have co-occurring mental health substance abuse disorders. When you look at our highest inpatient risk, average age is 53. So we're not looking at a really elderly population, but we're looking at a very high needs population. And as you can tell, we are not looking at children by and large with this group. So what we have done to really build a robust pediatric program within our ACO is partner with several of our community partners and pay them for what they do as a management fee, because they're doing some things that are really very innovative and really very helpful. So we're looking at the Child Health Investment Partnership of the Roanoke Valley, and they have home visiting with a health focus. So they use parents as teachers as their evidence-based model, but also have incorporated an oral health, asthma management, pregnant moms program, and a behavioral health program. So the care management design is we have a home visiting contract where our members, we're paying per member per month to our home visiting organization. And they coordinate with our care managers within the health plan. So most of your health management organizations will have a nurse at a health plan calling and talking to a patient. And what we know is that high touch, in-person, in-home is much more effective. And if we provide that and then we collect that data within the home, including what we report as HEDIS metrics and health outcomes, we wind up reducing costs as well too. So how that works in a practice setting with medical home is that we build our system around the child and family. So we have a shared in-basket through our electronic health record with our home visitors, and we make electronic referrals to them. One of the things that this group does is they provide transportation, and that's part of the per member per month that we pay them through the Accountable Care Organization. One of the neat things that happens is that developmental screening results are shared. So our home visiting group does developmental screening with all of our children that we have referred to them, and they share those results to us. So many times before that child comes in for their well-child visit, we know the results of their ages and stages questionnaire or an MCHP, and they've already been referred into early intervention because we have this wraparound system built for them. The other thing that's really neat about this is that anticipatory guidance is reinforced in home. So we think about anticipatory guidance in pediatrics as bright futures and the number of things that you need to discuss with families. when in fact that's often not a real efficient way to do that and not a real efficient use of our time. It's much more efficient if we answer the family's questions and concerns while they're in the office and work with our home visitors who know where the safety problems are in the home and know where some of the developmental problems may be with that child and know what some of the problems between maternal-child and parental-child conflict may be, and allowing them to do some of the anticipatory guidance that's Bright Futures based in the home. And then finally, oral health education and fluoride. Pediatric dentistry is something that we're beginning to develop more of a capacity for in southwestern Virginia, but it has been a real problem. And so what we do with working with these nurses is we work with them, and they, in their home visits, will do oral health assessments and fluoride varnish for all of our kids and referrals to dentists. So I can tell you right now we have about 66% of our kids have made it to a dental visit before 3 years of age, which is pretty good for a Medicaid population. So the oral health and fluoride varnish is one program we have. The asthma case management, what our nurses do is go into the home and they assess the environment and modifications. And as you can understand, talking about environmental modifications while you're in the home, getting rid of the dust bunnies, what about smoking, what about some of the other things that are there, may be really helpful for a child who might have recurrent ED visits or recurrent hospitalizations for asthma. Our nurses observe inhaler use. They do asthma control assessments as well as asthma action plans and education, and then they're transported to either their primary care doctor or a pulmonology visit. The behavioral health program that we have runs from prenatal to age 7 and starts off with perinatal depression screening if we're able to get a family in while mom is pregnant, and then follows with postpartum depression screening. And then finally, connection to services for parents and children who are at risk and diagnosed, and transportation for those visits. So one of the things that's really innovative about this particular nurse home visiting program is that they'll provide transportation for both the parent to their therapist and the child to their therapist. Because as we know, a lot of infant behavioral health problems really have everything to do with the environment and exposure to toxic stress with these kids. So if we look at some of our results that we're able to report within the ACO, 100% of our children have a medical home. 90% of our 2-year-olds are up to date on their well visits and immunizations. 100% have been screened for lead, hemoglobin, and development. We have 100% of our children with a dental home over age 3. 66% of those kids have had a visit by age 3. And 97% have had at least one oral health assessment and fluoride varnish. In our asthma program, 2011 to 2012, we had 145 children. 84% of them were well controlled with minimal inhaler use. We have reported a 90% decrease in emergency department visits, and parents have reported an 82% decrease in school absence due to their asthma acting up. When we look at our in-home screening, when we started working with the Child Health Investment Partnership, what we found was that we increased our amount of developmental screening. When we looked at the percentage of our kids fully immunized by kindergarten entry, that is actually very close to about 93% with these kids. And then our pediatric asthma, children receiving the asthma case management went down to close to 0 after 1 year in the program. We modeled our home intervention pilot for prenatal care after a study that was done statewide in Virginia with another managed care organization looking at pregnant women and randomizing them to either having a home visitor or not having a home visitor. And what we found was that they were able to save a lot of money on the first year of life by decreasing NICU. And I'm going to speed this up a little bit because I'm running a little bit short on time, but I think that when we started putting our home visitors together with a nurse, we found that our increase in prenatal care happened, that more of our moms made it to all of their visits, that we were able to reduce our maternal smoking by 1/3, that are screening for perinatal depression. If you look at this, 25 to 30% of our moms screen positive for depression, but we were able to begin to get most of them into treatment. We reduced the number of kids in the Roanoke Valley region who were born under 37 weeks. Very interestingly, in Roanoke Allegheny, we brought our term low birth weight down to absolutely 0. And just to go through a couple of our other groups that we partner with here, Care Connection for Children is our state Title V program, and we regularly communicate with our Care Connection programs. I see a couple of our nurses on the call here. But we talk about our kids with special health care needs who are complex, and they are managed by our Title V nurses. But as a health plan, we want to know what it is that we can communicate and what we can collaborate and care for there. The other group that we collaborate with is a parent group, our Family to Family Health Information Center, and that's in our area at Special Families of the Roanoke Valley. And they have been very helpful in working with other families to get them connected to waiver services, to have successful IEP meetings. We had 10 hospitalizations avoided since January due to connection to home health services. They have had monthly support group meetings. They've got a Facebook page and a respite program as well too. So accountable care, just to wrap up, you're really looking at the health of a population. Our pregnancy outcomes are better, which is a big cost decrease because we have fewer premature babies. We've had decreases in our hospitalizations and emergency department visits. We've had increases in school attendance because of our asthma program, and we're looking and monitoring grades at this point. We're looking at monitoring parental education and employment because we're able to contract with our home visitors. And all of this is looking at the function and performance of the medical home within accountable care, and then as we're looking at our community partners for some of the metrics that they're measuring, because what we know is that it's easier to build strong children than repair broken men. And with that, I'm going to finish up, and there is a question here about the home visiting program. Was it a Title V MCH program or another program? The Children's Health Investment Program of the Roanoke Valley it's a nonprofit program. They are actually an MCHP program, MCH program as well too, and they are working on developing their behavioral health program through there. But the home visiting program is an actual, it's a private nonprofit. So with that, I'll finish up and let Chris move on to our next speakers.
Thanks very much, Colleen. Lots of information there, and I'm hoping it's generating questions, and I'll remind folks that it's time to start putting in those questions as they develop, because we're going to, after the next presentation, we're going to be taking those questions. The next group I'm going to introduce is the group from Oregon, which has 3 presenters, and I'm going to give you all 3 of the presenters so that they can go through their presentation seamlessly. We're going to start out with Don Ross, who is the Policy and Planning Section Manager, Division of Medical Assistance Programs, Oregon Health Authority, so Medicaid. Kate Wilcox, who is the Maternal and Child Health Section Manager, Public Health Division, Oregon Health Authority. And Marilyn Hartzell, who is the Director of the Oregon Center for Children and Youth with Special Needs. Okay, Oregon, take it away.
Thank you. Hi, everyone. Good afternoon. This is Don Ross with the Oregon Health Authority Medical Assistance Programs, and just a thank you to AMCHP. Our Oregon Medicaid's participation with AMCHP work is really through an invitation by our public health people, Kate Wilcox and Lisa Dixon-Gray and others here in Oregon who got us involved because they thought, and we think, a partnership between Medicaid and public health is a good idea toward reaching some of the goals that we're talking about here today. Go ahead and advance to the next slide. So what we're going to talk about briefly today is the basics of our coordinated care organizations, which is what we have in Oregon, and I'm going to highlight some similarities and differences between CCOs and ACOs. The goals are very similar to everything that's in the ACA and that are occurring with ACOs elsewhere in the nation, but we built something a little bit different here. So, and then Kate's going to talk about public health role in CCOs, and then we're also going to have Marilyn talk about opportunities for children with special health care needs. Next slide. So the lay of the land in Oregon when we began this work, and our governor was elected and not in office yet at the end of 2010. So post signing of the ACA asked us to begin to work on a model for transforming Oregon healthcare, beginning with Medicaid. And our situation was that well, actually a little bit more than half of the babies born in Oregon paid by Medicaid. 16% of Oregonians on Medicaid, and 85% of Oregon providers participating and enrolled as Medicaid providers. It was 11% of our total state general fund budget, and it was the fastest growing portion of the state's budget. So really at a crisis point, and of course the opportunity created in a situation like that is you have legislators and stakeholders willing to consider things that they might not have considered if not for really being on a completely unsustainable path. Next slide. This looks similar to one of the slides the previous presenter put up there. Of course, the obvious piece is that there are all these determinants to an individual's health, and really only 10% of it, at least historically, has been the medical care that's provided, the rest being what we're born with and what's in our environment and our social and lifestyle contributors. Next slide. Again, familiar messages to everyone probably on the phone today. The Triple Aim, the vision in Oregon, same as many other places, better health, better care, and lower costs through a reformed system for the delivery of care and the financing of care and the monitoring of performance. The coordinated care organizations are designed to provide aligned financial incentives at the local community level so that prevention, chronic disease management, and outcomes and equity across especially various ethnic groups, but also socioeconomic groups, are all managed, and the partners in these organizations include local doctors, pharmacists, hospitals, and ancillary providers, as well as mental health and dental providers and alcohol and drug providers. Next slide. The goal for changing the delivery includes that benefits and services are delivered in an integrated and coordinated way, that there be one global budget. A lot of feedback we got from stakeholders was that barriers to integration included in a large way that the funding streams were all separate for mental health, physical health, dental, and other types of care. Also metrics with standards for safe and effective care, local accountability, and in this case local defined as at the community level, and local flexibility. So we had to build a system that was very clear about where we want to get to, but provided some flexibility for those communities in using the global budget to figure out how to get there. While of course considering best practices and proven methods that are already easy to find. Next slide. So the integration and coordination includes, as I said, physical health, behavioral health, dental health, shooting for health equity, better prevention, emphasis on prevention, addressing social determinants of health, including education, supported employment, and of course, with the workforce shortage that we have in Oregon, and especially in rural parts of Oregon, we're looking at alternative ways to both perform outreach and deliver care, and that includes community health workers and non-traditional health workers. Collaboration and integration with other health and human services, including the long-term care system, public health, and schools and school-based sources of delivery of care. Okay, next slide. The global budget is a key piece of the CCO in Oregon, as opposed to describe at a very high level, the ACO model being a lump budget provided to the CCO to take care of the health of a population, and then incentives to increase efficiency and outcomes so that the savings can be shared. The global budget basically puts a cap on what's available to spend, and it provides that to the CCO to deliver the care. And while there might be some savings shared down the road if there are savings, the global budget also assumes a different inflation trend than we had seen historically in Oregon Medicaid. So we were looking at about 5.4% annual inflation trend, and the global budget assumes a 2 percentage points lower trend. So each contract renewal, our CCOs receive something closer to 3.4%, and that's all the money there is. So they have a cap on what they can spend, and they have to stay within that. The current system had managed care physical health plans, managed mental health plan contractors, managed dental care contractors, and there was a fee-for-service system to serve about a quarter of the population. Of course, the payments were based on procedures and charges and how many codes were billed, and there were no incentives for health outcomes. The global budget is one budget, accountable for outcomes and metrics, a local vision and shared accountability, and shared savings, and flexibility to pay for things that keep people healthy. And that really is that bullet describes services that might not have a code. There's an infamous or famous story in Oregon now about the air conditioner provided to somebody who would have been had to have been admitted into an institutional setting if not for the window AC unit that kept her in her home, and it's a legend out here now. Next slide. CCOs are governed locally. We also wanted consumer accountability to the local community, the community that's being served, not just to the state Medicaid funding system. So the law says that the governance includes all major components of the healthcare delivery system. The entities or organizations that share financial risk. There have to be at least 2 healthcare providers in active practice on the governance groups. The consumer advisory councils and the boards are what make up the governance system. Those can be primary care physicians or nurse practitioners, mental health or chemical dependency and treatment providers. There have to be at least 2 members of the community, and also at least 1 member of the community advisory council on the board of the CCO. Next slide. So some really distinct differences between ACOs and CCOs. The ACOs have some distinct features. They can include payers, but they're developed around health systems in many states. And they originally were aimed in the ACA at Medicare savings, although the hope is that they will generate some Medicaid savings as well. Providers in ACOs share, at least in the Medicare savings, through 3 different models, and those are listed there. The CCOs are accountable to the state and the local community. Oregon's Medicaid agency has made commitments in our waiver to CMS to some financial and quality goals, but the CCOs are accountable to the state's Medicaid agency primarily, and Medicaid enrollment in CCOs is mandatory and required. So all of our we're at about 90% managed care enrollment and about 10% fee-for-service in Oregon now. Most of the fee-for-service is either has other primary insurance or Medicare as primary insurance. So pretty much everyone else statewide is enrolled in a CCO, and that is required. In geographies where there are multiple CCOs, then eligible individuals and families have a choice between those. And I think that is my last slide.
You got one more, Don.
I do have one more. All right, next slide. Thank you. So the Community Advisory Council and this local accountability, again, a really big issue. It could be said that we had the Triple Aim plus one more aim, which was as long as we're improving the delivery of health care and the outcomes and reducing the costs, let's also make the Medicaid delivery system a system that produces high satisfaction for the users of it, so that the disabled and the poor don't feel like they're and in fact won't be receiving health care from a system that's second rate to the private system that privately insured people enjoy. So again, the community advisory councils are made up of consumers of the services, include representatives from local county government and county commissioners, and early on their duties include a community health improvement plan, community health assessments, and reporting on that progress. These CCOs just launched last summer, so we don't have outcomes data to share yet like Carillion does. That was really impressive, by the way, but we hope to have lots of good news like that to report in another year. Okay, Kate?
Good morning or afternoon, depending on where you are in the country. My name is Kate Wilcox. I'm in the State Public Health Division in the Maternal and Child Health section. And I think that our model has done a really nice job of ensuring that public health is integrated in a number of ways into this whole CCO transformation. I'm not going to read through all of this, but it is written in statute that the coordinated care organizations work with public health in some of the service delivery and case management issues. There's a strong connection with the community and recognizing the role that the community has in contributing to the health and wellness of the members of the CCOs as well as the population of that community. Likewise, you go from statute to contracts. So the state has contracts with each of the CCOs, and in those contracts it states deliberately that the CCOs will collaborate with local public health authority on a variety of functions. And I think this is a real hats off to recognizing that when you think about it, we probably only spend about 10% of our time in a clinical setting, and the rest of our time is spent in the community. And to what extent the community and our environment and what happens in the community impacts our health and wellness is actually written into statute and contract. So public health can bring the how in terms of what expertise do we bring to how do we help the members, the community actually improve their health at that level. This third bullet down represents several of the public health division's priorities in a recent strategic plan looking for reduced obesity, reduced tobacco use, reduced suicide, those kinds of things. So public health is integrated in a number of ways within the structure of the Oregon CCO model. Now, the first year, which we're coming into the tail end of, there were accountability metrics that sort of drive the focus of where the CCOs are. So Don talked about this in his slide that had the 5 boxes, that while they have global budgets, they have to use that money to meet these outcomes. It's really outcomes-based. And so this first year, they were reporting on these metrics that are listed here, and I have another slide of them as well. So you can see that, and this is really where the CCOs are paying attention. I would too. If I have to make sure my money is going to keep flowing, I'm going to make sure that I'm achieving the outcomes that the funder has set out for me. So a lot of this has to do with what I call the low-hanging fruit. How are we going to get the most return on investment as quickly as we can? So you see things like reducing the ED utilization and the repeat visits and things like that. But there are public health types of matrices here, or metrics here. Clearly, we're all looking at disparities, the experience of care, tobacco use, obesity, alcohol use. These are some that are we recognize as real traditional public health kinds of outcomes. We're moving into the mental illness and what that looks like in the community, contraceptive use, birth weight screening, developmental screening for children, depression, certainly in maternal mental health in that arena. So I think what we see in these first round of metrics are that they're designed to focus on how the CCOs can get their quick return on investment so they can meet the state and federal requirements. And that maternal child health is embedded in many, but they aren't necessarily called out. And to be quite honest, we all in the maternal and child health world were a little frustrated about that, knowing how important it is to look upstream and to focus, use a life course lens in order to really get some sustainable outcomes. But never fear, patience was the word of the day, because what is coming up next is the second round, or second phase, as I call it, of metrics that are going to be coming on the heels, because it's one thing to cut the immediate costs, but then you've got to be able to sustain those cost cuts. And the way that the sustainability is really going to be happening really points to maternal and child health. So you can't have sustainable obesity prevention if you aren't talking about breastfeeding, if you aren't talking about child obesity and the contributors to children entering school and what are the foods like for them. So adult obesity is not going to be sustained. I mean, you might be able to reduce it, but the sustainability comes looking at from maternal and child health. And of course, it's all about a lot in our world is around the life course. And so if you tackle these problems early on in the life stage, preconceptually, perinatal, early childhood, you're going to get lifelong wellness impact and what I call the lifelong wellness factor. So I guess the lesson that I've learned is don't get too upset around the first phase of this work, but be poised and ready to be at the table for as it moves into the sustainability phase of development of the Affordable Care Act. And some possible metrics for moving into this second phase that we're looking at is looking at a broader range of standards of care and practice. So Healthy People 2020, we're drawing on what do those goals look like. Bright Futures is embedded, but how can we do even more of that? The U.S. Preventive Services Task Force, what are their guidelines, and how can we get that onto the radar as a means of a metric? And, of course, our Title V priorities that change every 5 years, but 5 years is a long time in terms of the timelines we're looking at. And also don't forget to include adolescent measures. Those we sometimes focus way upstream, but we got to sustain that through the adolescent period. And we also need to look for means of coding or tracking the measure. The CCOs need to be able to report back on their successes, and so ensuring that whatever we're proposing and working on has a means of measuring and tracking is really critical. And some possible measures that we are starting to formulate sort of in this phase 2. First of all, we want to see how we can target the existing measures to be not just about obesity for adults, but targeting it specifically around proper weight gain during pregnancy and early childhood obesity prevention measures. Oral health is now starting to get some traction and be coming under the radar, into the scope of what the CCOs are looking at. Some pieces that maybe we haven't quite figured out how to track and measure and screen, but we know that there's important health consequences with positive parenting and payoffs. If there is positive parenting, how can we help the parents be more effective in how they function in the community with their families? Sleep hygiene. This is an interesting one. This is around our families and kids getting enough sleep so that they can function and be well. Positive youth development, family violence is a huge one. How are we going to get screening around families, ACEs, intimate partner violence, knowing that all of that leads towards a trajectory of increased or decreased chronic propensities for chronic diseases as adults. Safety and injury, and pregnancy and tendedness. These are just some ideas that we've been tossing around for this second phase. I did want to focus a little bit on the pregnancy and tendedness as an example. There's, in development in Oregon, a preconception health question that has been tested, and I think it's getting out there nationally a little bit, called the One Key Question. And the one key question is, do you plan on getting pregnant in the next 12 months? And it can really help to focus what the intervention would be. If the answer is yes, then you get that woman into preconception health care. So is she alcohol-free, tobacco-free, eating well, getting exercise, all of those things that lead to optimal, being in a really positive, the most optimal place you can be before you get pregnant. And if the answer is no, are they getting into contraceptive care? So this is an example of a metrics that we've been figuring out or wanting to see how could we get that into one of those that the CCOs might be accountable for, knowing the impact that that has on sustaining health and wellness for the members. Of course, public health can't exist without talking about data. We do need to pay attention to the electronic health records requirements and sort of what's happening with data interoperability, sharing, HIPAA issues, and if we're connecting with our education communities, how are we bridging the HIPAA and the FERPA confidentiality bridges. All of that's part of what's happening in the community. So we as public health need to be ready to be able to receive data from providers, and we also need to be ready to provide it to providers because we collect data that is very useful to them in terms of assessing where their community is, the health of their members, and then being able to report it back to the funders, be it the state and the federal partners. So with that, I'm going to turn it over to Marilyn to share the perspective of the children and youth with special health needs.
Hi, thank you. I want to first test and be sure that someone can tell me that you can hear me.
We
Hi,
can.
Marilyn. Yes, ma'am.
Okay, thank you. Although we are all in Oregon, I think we are all in different locations. So I'm Marilyn Hartzell. I'm the director of the Oregon Center for Children and Youth with Special Health Needs. That is our Title V Children with Special Health Care Needs program here in Oregon. And I approached my thinking about and comments today in terms of sharing both what we did and what I wish we had done, particularly if I were speaking to fellow Title V SHIN directors in looking ahead at partnering, and I would frame it as a partnership and working with affordable care organizations as they come forward. And I think first and foremost it's critical to get to the table and join the conversation as ACOs are being formed, so that you can both provide them information and share with them your experiences and opportunities on which they can build. I really think of the different functions that we've done in Oregon as being framed around advocacy and education, support, model building, and joining with through this opportunity with our CCOs for building relationships with public health, Children with Special Health Care Needs program for the benefit of that population. First and foremost, to build or firm up your partnerships with your champions within your state. For Children with Special Health Care Needs, we were able to draw on some champion primary care providers we have in our state to join with us in our efforts to inform the CCO development and design to assure that not only were children on the table and being considered in terms of how the processes roll forward, but in particular children with special health care needs. We called on our family leaders, and we pulled on our specialists. Our center operates within or in kinship with a specialty clinic, and so we had quite a bit of expertise available to help us and partner with us. Probably these are many people that you are already partnering with around your various programs and initiatives. It certainly required quite a bit of freeing up of our schedule. Took a lot of time to become familiar with the, still learning the laws and the requirements that the healthcare system is placing on our healthcare providers. And preparation and drawing on all of the data that you have available now to describe the population, to describe their needs, to bring forward some of the critical pieces of research-based data we now have about the effectiveness of systems of care for children with special health care needs that we have through our 6 performance measures. And so again, I think our first challenge was to bring the conversation to and focused on children and then the children with special health care needs population. That it is a complex population, that it's broad and inclusive, and that we're looking at those commonalities of needs across the population of individuals who have very high needs. We are spending time in educating CCOs and the provider practices involved with them about how to identify those children within a system of care, sharing with them what we know about screeners and complexity scales, and again doing this in a fast-paced partnership with our AAP state affiliate, our improvement project. So all of those partnerships have been critical to influencing the thinking about serving children with special health care needs within this kind of model. Most immediately as this started to roll forward in Oregon, out of our Ocean office, leadership out of this program, both administrative and medical, joined with the development of the CCO's criteria about how they would operate. And a particular point of critical access is through the community advisory councils in which we drew on our family leaders in our state. One of the conversations here in Oregon is that much of the work of CCOs is, and through the primary care health standards that come through the practices that are now contracting with CCOs, is around patient engagement. And we work hard to reframe that as a family professional partnership on behalf of these children. We think that patient engagement doesn't fully capture and advance that role of the family at the center of the child's life, and that it is more than linguistics or semantics, that we're really trying to bring alive, and it's working very well by drawing on our family leaders and sharing these experiences out of Title V, what it means to be a family with a child with special health care needs, and informing how we can build partnerships and systems that work for them. And I highlighted on that second slide characteristics of a family professional partnership that we've all relied upon for many years. Again, I spoke briefly to the fact that we see this as an opportunity for advocacy and education, something Title V is well primed for, and in particular encouraging our family leaders, our F2F and HICs, and community leaders to join the advisory committees. And we provide quite a bit of support through our Oregon Family to Family Health Information Center to our family leaders around the state who are working at the local level with the CCOs, both in terms of giving input and advice to how practices and procedures are shaped, and being part of that accountability movement. And I'm sure many of you recognize some of those 3 primary statements in terms of the family voice and what needs to happen. I think that we're well primed with the 6 performance measures we've been working with for over 20 years that describe effective systems of care for children with special health care needs. And there is research-based evidence behind many of those, and I would encourage that anyone take time to do their homework, to pull that data together, to be ready to take that to the table, along with a solid description of the population of children with special health care needs in terms of all of their complexity between your own needs assessment data, data that may come from your community-based programs that you have built an infrastructure for, and certainly the National Survey of Children with Special Health Care Needs. We find high receptivity in the opportunities we've had to date to that conversation, and a real interest at looking at how services can be provided in a way that will, in fact, interrupt avoidable emergency room visits and unnecessary hospitalizations. So that's a piece that I strongly would advance. Our public health community-based program, our home visiting program to the population of children with special health care needs, has been able to demonstrate that it is effective in meeting what are some of the key measures for our CCOs, and I suspect that our state is not alone in states across the country that have data that can demonstrate that their home visiting programs can and do assure up-to-date immunizations, the flu vaccination, annual well child visits and dental visits, as well as reduced ER usage. Those are things in our data system that we've been able to draw on in working toward building a partnership between the CCOs and the public health system on behalf of children with special health care needs. And this first year, as Kate was saying, is there's this tremendous emphasis on bending the cost curve, reduction of costs, and looking forward to that second phase, in that I think we all feel a strong commitment in our state toward all three aims, and most especially that access to timely and appropriate care such that we get the best health care outcomes for all of our children. In Oregon, we have, I'm on my last slide. I think I've been forgetting to ask people to advance the slide. So I'm on my last slide, in which we have been working within Oregon to build a model of a continuum of comprehensive care coordination that focuses on children with special health care needs, and almost regardless of complexity. I mean, that you might, the optimal continuum would serve children who are highly medically involved, but children who are less so would be served by community-based care coordination. So in our state, we have a system of care coordination delivered through home visiting. In our public health system, we serve about 2,000 children in that system at this point. With this new model, we would add in a regional unit of care coordination where we would have outposted around our state, which is quite rural, and frontier expert nurse care coordinators who then build a linkage into the tertiary care system where we would place a care coordination team within that tertiary care system, and that we would build an uninterrupted and continuous continuum of care coordination for this population. There's great interest on the part of our CCOs in this model, and we are beginning to make some headway with building contracts to implement this. So it is an opportunity for great creativity and shared model building and decision making with CCOs at this time. And I ran through that pretty quick, so I think I'll stop there.
Thanks very much. This is Chris Cuss. Thanks very much to the Oregon team for that presentation. It's always great to hear about states, how they're working on these new efforts. And we do have one other commenter, and then we're going to get into questions. Cheryl Jones from Iowa, who's a pediatric nurse practitioner with the Division of Policy and Advocacy and works with the Child Health Specialty Clinics, is going to comment specifically about MCH involvement. And Cheryl, if you can keep it to less than 5 minutes, that'd be great.
Thank you very much, Chris, and I appreciate the opportunity to be able to comment a bit on what's happening in Iowa. We certainly see the same types of issues that have been presented by the previous speakers. And I guess when I look at what I work with Child Health Specialty Clinics. We're the Title V program for children with special needs, but we work very closely also with public health and MCH providers. But as providers within the system, as whether it's special needs or MCH, what I see is the important aspects of what we need to be looking at in our roles. We have to be informed ourselves and knowledgeable. And participating in webinars like this was extremely informative. And really, we all need this knowledge. There's a lot of things happening, a lot of change. Everything's being reformed. And if we don't know what's going on, we are going to get left out of the process. We need to inform others of what we do. Certainly getting at the table is the big challenge. sometimes when you're not even sure which room the table's in, it can prevent some challenges. But it isn't just getting at the table with some of the ACO formation now. It's being involved when discussions about medical homes are held, when discussions about integrated health homes are being held, when your Department of Human Services is looking at their waivers and how are they going to provide services for these high-risk populations, and how is MCH going to be involved in those discussions is extremely important. So to be at the table during those dialogues is very important. And informing folks about what we do. We know what we do it well, but we don't always, I think, do a really good job of informing other people about what we do. And there were comments repeatedly made about the importance for data. And we see that as extremely critical. One of the things we're looking at in our agency is how do we document, we work with children with special needs, very high need population, but how do we document in a meaningful way what that care coordination is that we do and what difference is it making? And we also, I think someone said you were on EPIC, we're also on the EPIC electronic health record, and we are working now on electronic documentation. Who's doing it? Is it me? Is staff nurse? Is it our family navigator? What are we doing? And looking at what difference is that level of care coordination making. So we are looking at that. I think the other thing we need to do, and I think that was mentioned too, is the important thing about informing our policymakers, our legislators, about what this is. And I was intrigued with Oregon. I think you said that you are there's also actually legislation saying that there shall be coordination with the public health and the community health folks. We feel that's important in Iowa also. And actually, I don't know if you've heard of First Five. First Five is an initiative that's been going on in Iowa for some time. It's a way to support medical homes in terms of care coordination, follow-up. And this year, the legislature in Iowa appropriate over $2 million to be used to expand this initiative, and it includes child health, especially this year, so that we can start looking more closely at how we work with children with special needs in this initiative. But the important thing of this is it says that the Department of Public Health shall also collaborate with the Iowa Medicaid enterprise and child health specialty clinics to integrate the activities of this First Five initiative into the establishment of patient-centered medical homes, community utilities, accountable care organizations, and other integrated care models developed to improve health quality and population health while reducing health care costs. This includes family navigators, it includes nurses, it includes social workers. But one of the things we did this year in Iowa is we presented before the Human Resources Appropriations Committee, who was looking at how they're reforming Iowa's healthcare system, and they're really pushing the ACOs in the Iowa legislature. And our comments to them were, you're talking about the need for care coordination, you're talking about the need for data about the effects this makes. Public health, MCH, has been doing this for 100 years, and we do it well. How are you going to ensure that this is going to be part of the system you're developing in Iowa? And they have written this into legislation in several places, so we felt good about that. The other thing we feel extremely strongly about in Iowa as we look at whether it's accountable care organizations, integrated care, health homes, or whatever, is the absolutely important role of family navigators and family support. We don't call it care coordination. We call it family support because it's way beyond just coordinating care. It's the importance of integrating that family support into these networks. And one of the things we're trying very hard to do is to keep this message in front of other providers we work with, our policymakers, our federal and our state delegations, so that as they look, as they are now, at continuing to reform the system, public health and MCH is going to be part of it.
Thanks very much, Cheryl. That's helpful. And actually, I think Don put a note that if you can give AMCHP the information about Iowa's First Five initiative or a link, that would be helpful to our group. I want to thank all our speakers today. Appreciate the time you take and help us respond to our members' needs by presenting in this webinar. We've got about a little bit more than 15 minutes to go over some questions. I want to get through as many as we can, so I'm asking our speakers to be not too wordy on the answers, really precise. And I'll start out right now with a basic one. I'd be interested from both groups as to really defining how do accountable care organizations differ from managed care organizations. Colleen?
Hello?
Yep, you there, Colleen?
I'm here. Yeah, can you hear me?
Yep.
Okay. So an accountable care organization, it differs from managed care in that they really are looking at outcomes. There is leadership to be looking at the health of the next generation, and really understanding that if we're ever going to get healthcare costs down, we have to be proactive in building health as well as reducing and containing costs. Your typical managed health organization, and I think about the HMOs of the 90s, was all about the gatekeeper, which was the primary care physician who wasn't referring and wasn't providing patient care because that was it was cost, and cost was the only thing that was happening. Accountable care has everything to do with your quality of care, your better health metrics, and measurements to show that you are improving care at the same time that you're reducing cost.
Thanks much. Anything from the Oregon team you want to add to that?
The only thing I would add, this is Don, is the managed care concept of the 90s was all about risk, and the thought was if you give the financial risk to a contractor, then all the right things will happen. And that's not what happened. I think the difference in our arrangements are seen in the contracts. They're seen in the accountability to the local community and consumers and the governance model. They're in the contracts requiring alternative payment methodologies and not simply fee schedules and paying for volume. There are financial penalties for not providing complete encounter data and other performance metrics, all built into the contracts. And also the state made an investment in placing a state-employed innovator agent embedded within each contractor's CCO. So we're treating them more like a delivery system partner and not just a contracted vendor that we purchase the benefit administration from.
Thank you. There were some discussion on our chat specifically about how you deal with reducing inequities. And I'll start with Oregon. You made some comments about that. Do you measure those inequities, and also how do you deal with that?
I think my partners here in Oregon are going to have some things to say about this too, so I'll be brief. But we are cutting our data up by ethnicity and by eligibility category now, so it's not all just aggregate Medicaid cost and quality data, and we think that's going to be very revealing for us. And we also have established Office of Equity and Inclusion, and again included contract terms in our agreements with the CCOs that they have specific plans to share with us around reducing ethnic disparities and promoting equity in the delivery of care. And that includes, again, the non-traditional providers and community health workers, and goes beyond simply being bilingual, but to delivering the care in a culturally competent way, depending on the specific patient and household need.
Anybody else want to add to that?
This is Kate. Just an additional piece is that public health can provide a lot of that data, and that's a really strong role that we can play and that we're hoping to play and have started to play with CCOs to help illuminate what is going on specifically within their CCO communities.
Thanks. Another theme that came out, and again it was in the chat, was the idea of involving families in design, and are there measurements relative to their experience about this? And I know particularly the discussion about children with special health care needs emphasize that, but does anybody want to add more to that comment? How are families involved in more the policy level in how ACOs play out?
I'll take a quick step, although I think Dawn might be able to respond to that. What we're doing out of our program and in partnership with our Oregon F2F is literally encouraging we have quite a network in our state of family leaders that we have developed over many years, and most recently in partnership with our F2F. And so for those individuals who are living in the communities where these CCOs are shaping up or have come into the being, is encouraging them onto the community advisory councils. And so we have, I think, it may only be 5 at this point, of our key family leaders who are participating on the community advisory councils, and these are in distant locations around Oregon. We're based in our one large metro area in Portland, and so linking them to the various resources that they might need to help with their own self-education, and then being able to support their stories and input into their advisory councils. I do think it's really important to have your data and information ready to be available to those people, but I'm impressed with our family leaders how much strength and leadership they're demonstrating around our state. We don't have measures of their experience other than that they keep calling us for more information as they go back to the next meeting.
Thanks. Colleen, anything you want to add to that?
Nothing more specifically that I can add to that there.
Okay. Another specific question we had here is, can you talk about the challenges and the enabling factors involved in integrating community health workers, such as community-based doulas and breastfeeding peer counselors, into affordable, accountable care organizations?
This is Marilyn Hertzel, and I may not quite hit this mark, but we have experience here in Oregon in having embedded and partnered with our public health nurse home visiting program in 4 of our counties that are high Hispanic populations, promotores that have been working in these counties now for 10 years or more. And that has been a very successful activity in which the promotores work under the supervision and with the shared care plan that's developed with the family by the nurse. So we have that experience through our public health model. We are also building linkages and support systems to a burgeoning workforce known euphemistically as care coordinators who span all disciplines. So as we are beginning to build linkages and support to this emerging workforce, we are talking to people who may be highly experienced nurses, may be social workers, may be family members who are coming to clinics to take positions. And so this is where I probably am not hitting the mark. It takes I think there's a huge education piece and workforce development piece here to carry forward to make that work. So that's a limited response, I think.
And Dawn, with Oregon Medicaid, the only thing I would add is there's enabling legislation in our statute now, and also in our waiver with CMS to pave the way for the types of workers that have been discussed, as well as the Office of Equity and Inclusion is building the certification and training programs for those. So I think that the groundwork is done to increase opportunities for people to enter those careers and to produce a evolving workforce for delivery of health care and social services that will fill these gaps between the conventional system and where we want to be.
And this is Colleen. The way that would be approached through the Accountable Care Organization would be contracting with these individuals and contracting with groups of these individuals, because they play an important care coordination, if you will, role, or family support role. And if we can charge them with trying to improve the health literacy of our population, which then translates to appropriate health services, less ED use, less hospitalizations, then that's a group we may contract with, very much like what we've done with the home visitors.
Thanks much. I know we have some AMCHP staff on the phone. Any burning questions that in the last 4 minutes that folks want to pose to the presenters?
Hi, Chris. I think there's still some good ones. I snuck a couple in there already, so if there's some good ones in the chat box, let's keep going on those.
Okay, okay. I've got one more I think that we can go here, and I think one of the ideas is that the ACO, the Affordable Care Act, and ACOs is really trying to move more to teen care, and which is really a change in practice. And one of the questions was, and I think, Colleen, I'll start with you because you responded to it on the chat, how do you address helping providers and practices make these changes?
So that's a great question, and you have more control over the practices that you own or that are really part of that accountable care organization. So within Carilion Clinic, we were able to fund most of our primary care practices, and we have 27 of them in our area, to become Level 3 patient-centered medical homes. And so the process is there, the connections are there, having a care coordinator that a busy physician can help them out with connecting someone to services has been something that's really been very helpful. There are some accountable care organizations out there that actually, as part of their recruitment for a primary care practice, may help them through Level 3 patient-centered medical home. The other thing that Carilion did, quite honestly, was change their contract with their contracted physicians. So we are paid on a salary with bonuses that are tied to quality metrics that we define. And then a piece of that is how the system does financially as a whole. So everybody is watching out for all of that. So if a visit can be avoided or an ED visit can be avoided by having a care coordinator work and work with somebody and get them connected to a community resource, then we all win with that. And that is actually, in some ways, has been very helpful because everybody across the board got that contract. And so some of our surgeons and some of our radiologists who didn't want to work in that way left, and we replaced them with people who are really very much devoted to improving care and reducing costs in the system.
Interesting. Oregon, any comments in that area?
Very similar to what you just heard. 300 plus, close to 400 patient-centered primary care homes in Oregon certified at this point, many of them third tier, and like Colleen just said, shared risk, not just risk to the providers in the system, but linking the success of each one to the other so that they have a shared risk for the population, so that in other words, finding ways to pay a hospital for an empty bed, not just a full bed, finding ways to pay consulting specialists and surgical specialists for something other than doing procedures or ordering more diagnostics. So.
Well, thanks a lot. We're at the end of the time, and there's a lot more to go over, so it looks like we'll need a DEF of MCOs, not as pithy as a title. But again, I'd like to thank our presenters, and I'd like to thank our attendees for being on the call today. We hope you found this to be value added for your work and that you'll share the information with your colleagues. Again, this webinar was recorded, and the link to the recording and the speaker slides will be posted to the AMCHP website in the next week. I'd also like to remind you to please complete the brief evaluation that you will be emailed shortly. I'd also say that AMCHP has lots of resources on this and other topics related to the ACA on its website, which is www.amchp.org. And again, thanks everyone. Have a great rest of the day, and goodbye.